you very much for that introduction. I wanted to thank Susanna and her team, since I'm the last speaker, for putting on an excellent conference. And I also wanted to welcome and thank our friends from Tampa and Sarasota joining, especially my mother, so Dr. Sunita Sharon. So thank you everyone for attending. I'm going to talk about autoimmune hepatitis. In the interest of time, I'm going to talk about the diagnosis and treatment. I've left out a lot of the pathophysiology and the genetic part. Initially, this presentation was about 30 minutes, but I was asked to truncate to about 15 minutes. Next slide, please. Hope you find it interesting. So autoimmune hepatitis is the hallmark is chronic inflammatory liver disease with circulating autoantibodies and also elevated serum gamma globulin levels. You've got acute hepatitis, chronic liver disease, and if untreated, extending all the way to cirrhosis. In between, you also have acute liver failure. Next slide, please. So incidence and epidemiology presents at any age, usually higher incidence in women, any ethnic group, bimodal distribution, peak you can have in the second decade of life and in the fifth and sixth decades of life also. Incidence is about 2 per 100,000 per year in Europe, and prevalence is 11 to 25 per 100,000 population in Europe also. There's no prevalence data which exists in the United States. Next slide, please. So clinical features, most commonly it is diagnosed or it comes to our attention in abnormal liver biochemical tests, which are checked yearly as part of routine lab work. And present as acute hepatitis, acute liver failure, and cirrhosis. Symptomatology, extra hepatic manifestations. You can be asymptomatic most commonly, anorexia, fatigue, weight loss, abdominal pain, itching, and arthralgias can be present. In a study of 303 patients with acute liver failure of unclear etiology, actually 11% were thought to have underlying autoimmune hepatitis at the end. Next slide, please. Associated clinical disorders with autoimmunity, you can have autoimmune thyroiditis, rheumatoid arthritis, type 1 diabetes mellitus, ulcerative colitis, SLE, and most importantly, also a higher incidence of celiac screw in 3 to 6% of the patients. Dermatologically, you can have a transient maculopapular rash over the face, trunk, and upper extremities, which is resolves by itself, 8 to 17% of patients have presentation. Next slide, please. We'll skip this slide. So laboratory work, liver function and biochemical function tests, the elevations in ALT and AST, they may exceed 10 to 20 times the upper limit of normal. The ratio of alkaline phosphatase to ALT or AST is less than 1 to 5. You may have slightly elevated alkaline phosphatase and slightly elevated ALT, AST level when there's chronic liver disease present. And then the ratio drops to less than 1 to 2. Elevations in gamma globulin, particularly IgG, but does not have to be universally present. Next slide, please. So going through the auto antibodies, generally the higher the antibody titer greater than 1 to 60 provides a greater support for the diagnosis compared to lower titers. ANA, most commonly present. Titers of 1 to 80 or 1 to 100 or greater are regarded as positive in adults. Anti-smooth muscle antibody, more specific, particularly when present at 1 to 80 titer, and it is, however, less prevalent. Anti-LMK, anti-liver, excuse me, Anti-LMK, anti-liver kidney microsomal antibody type 1. Most commonly occur in patients with type 2 disease. And however, it is a rare find. AMA, anti-mitochondrial antibody, can occur with frequency ranging from 8 to 12%. However, in studies with more rigorous definition of AIH, it's only been found in overlap syndromes. Anti-DNA antibodies. These are antibodies to double-stranded DNA, most commonly associated with SLE, and can be found in autoimmune hepatitis in types 1 and 2. Next slide, please. Short slide, there's no characteristic imaging features of autoimmune hepatitis. Next slide, please. So histology, if you take a look at the top left slide, that's actually a pretty good slide of autoimmune hepatitis. The findings are of a limiting plate of the portal tract is disrupted by lymphoplasmacytic infiltrate. And in the middle side there, you can see a portal, you can see a bile duct. And then that's the limiting plate right there with the infiltrates all around it. And on the right side, you can actually see a rosette forming. You can actually also see multinucleated giant cells. However, none of those are present in here. Obviously, the hyperpigmented pink cells, which I don't know if you can see well or not, are the eosinophils, which can be present also. So the interface hepatitis is the hallmark of diagnosing autoimmune hepatitis. Next slide, please. So in this slide, on the top left and the bottom right, you can see lobular infiltration with the lymphoplasmacytic cells, and you also see a small amount of proliferation of the bile ducts. Next slide, please. So ductal injury and ductal reaction may be seen in 80% of patients at the time of diagnosis. Granulomas are uncommonly seen, and if they are seen, you should be thinking of primary biliary cholangitis or sarcoidosis. And as we mentioned, you can see rosettes of hepatocytes and multinucleated giant cells. Next slide, please. So in order to diagnose autoimmune hepatitis, we've gone through some of the autoantibodies you can check. You're checking the ANA, ASMA, anti-LKM, and AMA. However, they're all negative. You can check anti-liver cytosol antibody. You can check anti-soluble liver antigen, liver pancreas, and p-ANCA, which can be associated with PSC, and obviously you're checking the IgG level. Is obtaining histology always necessary? Not if you have high titers of the autoantibodies. And however, if you look at some of the algorithms, especially the European Association for Liver Studies, since 2015, their recommendation has been to check a liver biopsy because it can not only guide the diagnosis, but also guide treatment. Next slide, please. If you see more of a cholestatic pattern, even though the antibody is positive for autoimmune hepatitis, you have to exclude PSC. Think about PSC, especially if patient has inflammatory bowel disease, and MRCP should be obtained in these patients. Next slide, please. Type 1, type 2, these subtypes have not been established as distinct clinical or pathophysiological entities. However, type 2 can be more difficult to treat. Type 1, positive ANA, positive ASMA, typically adults and adolescents. Type 2, either ALK-M1 alone or positive anti-liver cytosol type 1. The latter, typical in infants, girls, and young women. Titers of anti-LKM antibodies, positivity at 1 to 10 is considered significant. Next slide, please. Next slide, please. So overlap syndromes. This could probably take up a whole lecture in itself. However, in going through overlap syndromes, lots of times you can have autoimmune hepatitis. However, it's you have all the features of a cholestatic disease, including they meet all the criteria for PBC or PSC. However, these patients also have disproportionately elevated serum transaminases and or IgG levels. So then you have to think about autoimmune hepatitis. By this point, you probably already have obtained a liver biopsy. If it's PBC with features of autoimmune hepatitis, consider treatment with corticosteroids and ursodeoxycholic acid. If it's features of PSC, then consider treatments with corticosteroids. Next slide, please. So there's an extensive diagnostic scoring system because as you can tell, sometimes given the elevations, the mild to very high elevations of autoantibodies, the mild features on liver biopsy to diagnostic features of autoimmune hepatitis, the diagnosis and sometimes with overlap symptoms, the diagnosis can be difficult to make. So 11 international centers for liver disease got together and then came out with the simplified criteria for diagnosing patients based on autoantibodies, IgG levels, liver histology, and exclusion of viral hepatitis. Next slide, please. So this is a point-based system. You, on the top left, autoantibodies, you assign 1 point if ANA or ASMA are 1 to 40, or if they are higher, or if you have anti-LKM antibodies greater than 1 to 40, then you assign 2 points. Top right, IgG, assign 1 point if it's greater than 1 time the upper limit, if it's greater than 1 time the upper limit of normal, or assign 2 points if it's greater than 1 to 1.0 times the upper limit of normal. Bottom right, histological features. If you have lymphocytic infiltration, you give 1 point, which is suggestive of the inflammation. However, if you have intraphase hepatitis, you give 2 points. Bottom left, 2 points if you have excluded viral hepatitis. Next slide, please. So validation of the study, the simplified scoring system had 88% sensitivity and 97% specificity compared to compared with a clinical and histological reference standard when using a cutoff of greater than 6, and that was 81% and 99% respectively when using a cutoff of greater than 7. So the diagnostic scoring has good sensitivity and specificity. Probable diagnosis if your total points are 6, and definite diagnosis if it's greater than 7. Next slide, please. So confounding factors in AIH, obviously it's the, it can be the overlap syndromes, but it's important to exclude drug-induced liver injury, take a good history of all medications that the patient has used, including over-the-counter supplements and especially workout supplements. Portal neutrophils are very common in drug-induced liver injury. Next slide, please. So treatment of AIH. So the indications for treatment when you do decide to treat is the serum immunotransferases level if they're greater than 10-fold the upper limit of normal, or serum gamma globulin levels greater than twice the upper limit of normal. If you don't have the criteria on the left, if the serum aminotransferase levels are greater than twice the upper limit of normal, then you should treat if you have symptomatology or elevated gamma globulin levels, even if less than twice the upper limit of normal, elevated conjugated bilirubin level, intraphase hepatitis on biopsy, or histological features of bridging necrosis or multi-acinar necrosis, or cirrhosis with any degree of inflammation on biopsy, and you should treat in children. Next slide, please. But you may not treat if, and it may not be required if the patients with normal or near normal serum aminotransferase and gamma globulin levels who have minimal necro-inflammatory activity on a liver biopsy. Treatment is not recommended for patients with cirrhosis and inactive disease. Next slide, please. The American Association for the Study of Liver Disease recommends either therapy with monotherapy or you can treat with a combination of glucocorticoid and azathioprine. Next slide, please. So this is kind of like a busy slide, but on the bottom left, if you have mild disease, asymptomatic patient, aminotransferases less than 10 times the upper limit of normal, you can do prednisone therapy. You can start with prednisone therapy as a monotherapy, 10 to 30 milligrams per day. If you feel that the patient has more severe disease, if they meet the criteria for more severe disease, prednisone monotherapy starting at 40 to 60 milligrams daily, or prednisone 30 milligrams daily, and azathioprine in combination with the prednisone at 50 milligrams daily. After 1 week of therapy, taper prednisone down by 5 to 10 milligrams per week. You want to follow serum aminotransferases and bilirubin levels and or IgG levels weekly. And then for ongoing management, if you have recurrent symptoms or worsening laboratory values during the prednisone taper, then maintain at the lowest dose of the prednisone, in which provides biochemical improvement. Next slide, please. So treatment pearls, we can ignore the left side, which we've already talked about. 6-MP can be tried in patients who are intolerant of azathioprine, which is a metabolite. 6-MP, it's important to remember you have to use half the dose. And then the combination therapy with budesonide and azathioprine is a reasonable option, although not extensively studied, especially in patients. You can use them especially in patients who have side effects with glucocorticoid therapy. Dose of azathioprine also can be increased to a maximum of 200 milligrams per day in order to achieve remission. Next slide, please. So you've started the induction therapy. 65 to 80% of patients will go into remission, which is your goal. Incomplete response to therapy will be in 13% of the patients, and 10% of the patients will fail to respond to treatment. Next slide, please. So what is remission? A resolution of symptoms, normalization of aminotransferase levels, and more likely these people are to achieve histological remission, who have normalization of the aminotransferase levels, normalization of serum bilirubin levels and gamma globulin levels, improvement in liver histology to normal or only mild portal hepatitis, or minimal to no activity in cirrhotics. And the average time to remission at treatment is 18 to 24 months. So these patients are in the long haul for immunosuppressive therapy. Next slide, please. So once you have patients in remission, so what do you do subsequently? Every patient pretty much in autoimmune hepatitis deserves treatment to be withdrawn at drug therapy to be withdrawn when they have achieved remission. So you don't want to do that right away. After 24 months of remission, then you can think about withdrawing therapy. At that point, we obtain a liver biopsy. If there is still interface hepatitis, then you probably don't want to withdraw treatment at this point. It's been shown that HAI score of greater than 4, they have a poor prognosis with excess mortality, and the regression of fibrosis is less, 60% versus, 32% versus 60% if your HAI score is less than 4. Next slide, please. So after 24 months of remission, you want to start the prednisone taper, decrease by 10 milligrams per week till you have them down to 20 milligrams. And after 20 milligrams is 5 milligrams per week till you have them down to 10 milligrams. And then you want to go down slower to 2.5 milligrams per week. Monitor aminotransferases every 3 weeks and while tapering, and then 6 months, and after that annually. Next slide, please. If they're on an azathioprine taper, if taking 50 milligrams daily, then stop the azathioprine. If taking higher doses, then go down by 50 milligrams every 3 months, and continue monitoring the aminotransferases every 3 months. Withdrawal of azathioprine should be after the prednisone has been withdrawn. Next slide, please. So after you've successfully withdrawn therapy, what is the prognosis? Histological remission before the withdrawal of therapy, they have a 20 to 30% chance of relapse, which is a pretty healthy chance here. Evidence of interface hepatitis, there's about a 75 to 90% chance of relapse. However, once the patients relapse, 80% of them will respond to retreatment, and then they are maintained on the lowest dose of the medications which they were previously on. Typically, that comes down to prednisone about 10 milligrams per day. Next slide, please. So after they have relapsed, if you want to maintain them on azathioprine, take off the glucocorticoid, you can actually increase the azathioprine up to a maximum of 200 milligrams per day, and then taper down the azathioprine again by 50 milligrams every 3 months. If you have partial suppression, if they keep relapsing during this, during the tapering of the azathioprine, you can also maintain them on prednisone, and usually that comes down to about 7.5 milligrams per day. Next slide, please. Some clinical considerations: if aminotransferases stay elevated, consider underlying NASH. And if gamma globulin levels stay elevated, consider other underlying autoimmune disease. Next slide, please. So that was remission and relapse. However, if you have incomplete response to therapy, which is defined as some or no improvement in clinical, laboratory, and histological features, despite compliance with treatment for 2 to 3 years, and no worsening of the clinical condition. Next slide, please. You can increase the dose of azathioprine and increase the dose of the prednisone again, and then go down and titrate down to where the biochemical response is. You can also check 6-TG level and add allopurinol as necessary, but after you add allopurinol, the 6-TG levels need to be very, very closely monitored. And you can also switch from azathioprine to CellCept, 1 gram twice a day, and 1/3 of the patients will experience side effects with the CellCept. Next slide, please. Other considerations, budesonide or cyclosporin, they all show promise. However, there have not been extensive studies with these agents. Next slide, please. Other considerations also, ursodeoxycholic acid is ineffective, and methotrexate, infliximab, and rituximab have increased risk of sepsis and show equivocal response. Next slide, please. Now, the small number of patients who go into treatment failure, they have sustained biochemical and histological activities leading to development of worsening disease with cirrhosis and eventual complications and death. They have a need for liver transplantation. And these patients, you should also consider overlap syndromes, especially with PSC, and if it's a young patient, with Wilson's disease. Those with HLA-8 phenotype and African-American males have a higher rate of refractory disease. Next slide, please. Special circumstances in acute liver failure, there is a role for using steroids. However, septic complications are high. If you have severe disease, you can use prednisone or prednisolone and follow the MELD score closely. Studies have shown the higher the MELD score, the higher the response initially, but also higher the sepsis rate. So in reports, response to glucocorticoids in severe disease has ranged from 36 to 100%. Next slide, please. Pregnancy, glucocorticoids, and azathioprine, even though azathioprine is category D, has been used and appears to be safe. Cellcept is not safe in pregnancy and should be withdrawn 3 months prior to conception. And AIH itself has been associated with increased risk of fetal prematurity, low birth weight, and demise. Patients should be monitored for flares during pregnancy and in the postpartum period also. Next slide. If you have cirrhosis, whether compensated or decompensated, treatment should not be held. And you can see regression of fibrosis, as in 97 patients studied who had pre-treatment and post-treatment biopsies. They had 8 out of 14 patients had regression of their fibrosis. Coexisting hepatitis C and autoimmune hepatitis, if you're planning to use DAAs in treatment, then you don't have to wait for the direct-acting antivirals. However, if you're planning interferon-based therapy, then the autoimmune hepatitis should be treated first, followed by the interferon and ribavirin-based therapy. Next slide, please. To summary, confirm the diagnosis with labs and histology. Mono or dual therapy is indicated. Attempted withdrawal is usually biochemical and histology-based, and sometimes symptomologically based also. And then coexisting diseases we should look for if they're not responding to therapy.